Now what we want to do is spread the canvas a bit more widely to think about how we can use the opportunity of this to think about the importance of using outcomes data to drive improvement. And part of the purpose of the new organisation, NHS Improving Quality, is to support improvement and help support the use of information and measurement to drive improvement in clinical services. There has been much written about improvement science and so on, and I think it's vital that we think about this issue in the context of the wider one about providing the right culture and stimulus for improvement in healthcare services with the patient at the heart of our concerns, and thinking about the kinds of tools and techniques that we can use to help support and drive improvement. And that's certainly of great interest to us in NHS IQ as we support this piece of work and many others. And I think there's a real challenge for you as leaders of local healthcare systems to make sure that those messages are filtered through locally and that the right kind of improvement cultures and learning exists within your own organisation, so that the publication of outcomes data and the increasing transparency we'll see are seen as positive and are seen as beneficial in terms of continuously improving clinical services. So it gives me great pleasure to introduce Professor Moira Livinngston. Moira is the Clinical Director of Improvement Capability for NHS IQ, and Moira is going to take us through the next session. Moira.
Thanks very much, Julian. So I'm going to cover the challenge and then kind of explore with you really the issues of purpose, data, culture, finishing with the impossible dream. But I promise not to burst into song because that would be really unfortunate. When we're thinking about improving quality, there's a couple of things that most organisations would set off and do at the start. And the first is to really set the tone for quality improvement, the focus, make sure the branding is right, set a challenging vision that gets people excited and on board. So Apple do this really well, don't they? An apple on every desk. Very few of us would challenge the quality, customer care and design features of Apple. But you see the Apple sign, it instills a kind of an emotion in you. If you walk into an Apple shop, the staff all behave in the most customer-centred, quality-focused way with you. Chanel, another big brand. And actually, they're really bold in their ambition. They're not shy. And actually, to be the ultimate house of luxury, defining style and creating design now and forever, that's ambitious, but actually they get their staff behind them in supporting that. I'm going to just put up some mission statements, and I want you to just shout out the brand. Inspire and nurture the human spirit, one person, one cup, one neighbourhood at a time. Starbucks, okay. And they're having a difficult time in the press at the moment. They haven't changed their mission, actually. They're sticking with it. Okay, so that one's Virgin. And the last one, I really like that, tools for the mind that advance mankind. And of course that has to be Apple. And I don't have shares actually, and I need to kind of declare there's no interest in Apple. But the NHS, it's rather complicated. And I've used the word complicated, not complex, because I think it's complicated. That actually we're not an organisation. We're a system, but within the system exist lots of organisations, all with different purposes, all with different visions and missions. And then alongside that, we have professional bodies, which again, we align to. So it really is a very complicated system. Trying to get a shared core purpose or vision or a core brand, which helps with some of these really challenging issues, is very difficult. And of course, what do we then experience? Well, even when there's a good story to tell, hospitals set to introduce Rate My Doctor scheme, there is always a way of spinning it. And there's something about the fact that you're hearing Norman talk about the work that's being done with the press. Clearly, there's a lot of work to be done with the press. But actually, we've also heard that the press have been instigators of change and improving quality. So actually, if we hadn't had the press adding to the pressures around the cardiac surgery issue, we maybe wouldn't be where we are today. So when we think about our purpose, going back, when the NHS was first set up, the purpose wasn't about quality. It was actually providing medical care free at the point of need to all Britons. Didn't matter how bad it was, actually, we were just going to provide it. NHS England vision has really tried to challenge that. And NHS England, as an organisation, clearly isn't the organisation that many of you belong to, but it's the leadership body which is helping us understand where we need to go to get where the health service needs to be to serve the people of England properly. And constantly improving is a big feature. And of course, when you actually see the report and the headings around this work, it's very difficult to argue with any of that. You know, we all emotionally feel that that's right and intellectually feel it's right. So what is it then that causes us the challenge in moving it forward so that we can be better at transparency, be better at choice, improving patient participation and higher standards? I'm not sure that there's anybody who is professionally registered could argue against any of those things. So I think that when we think about the successful launch of a programme like this, it is important to get the focus right. It's important to have the patients and the public at the heart of this, but to recognise that this is being clinically led. It's being professionally led by the colleges, clinically led through people like yourselves who are here today, who will take messages back to your local area and lead clinically. And right the way down to the consultants who are going to be leading this ahead of the world in terms of transparency of individual outcomes. That's the surgeons in England, which I think is fantastic. But there's also a great opportunity to align this with things that we just take for granted. So the Everyone Counts report, but actually the Constitution. This is inbuilt into the Constitution, and the Constitution covers the whole of the NHS, whichever part of that complicated system you belong. And of course, good medical practice. We can't deny, if we're practicing doctors, that it is a requirement of us to do the best by our patients, to do them no harm, and to always make sure that they get the best possible treatment available to them. But we do have this issue about the NHS brand, and I kind of like the idea that we should be uncompromising in our commitment to be better. And I guess that's where the improvement world enters what might otherwise be seen as a world of judgment. But there is also another element to how we want to look at this work, and part of that is really what can be done nationally and appropriately done nationally, but what needs to be done locally. We know that if you're going to make the biggest impact on quality of patient care, it's about the work that happens locally. So actually we need to be thinking how that work can be supported to help move forward this important initiative. So thinking about the data, we've heard quite a lot about the data, and part of this is mindset, of course, and I think over years, where we've had a kind of target-driven healthcare system, the issue of data has been quite tricky because it has a lot of negative connotations, and we're now asking people to turn that on its head and start to see data in a more positive way. So the mindset needs to change. But actually, for the mindset to change, we actually have to change how people think and feel. Do we trust the data? Do we trust that we're going to be treated fairly? Do we trust that the culture will respond in a way that is underpinned by the commitment in Everyone Counts, which is about quality improvement? Bob Lloyd from the Institute for Healthcare Improvement in the States, he's a kind of measurement expert. And what he says is actually the data is the same, but you can choose how to use it. And it's the mindset of the people releasing the data that makes a difference to how it's used. So it's not that it's different data, but you have to understand the data, but it's how it's presented and how we choose to use that data that's really important. And of course, Don Berwick and Brian Jarman also have done a lot of work with clinicians in trying to understand why we spend so much time discussing the data and not discussing improving the quality of the experience or outcomes for patients. And I think doctors tend to go through these 4 phases at different paces. And particularly when the data is being used for judgment, the data's wrong. Then the data's right, but it's not really a problem. Data's right, it's a real problem, but it's not my problem. And then, of course, the data's right, and it is my problem. And professionally, I'm obliged to do something about it. I want to be better. There is something about the fact that can we ever have perfect data? What would it take? And I think Ben was talking about that, that we can argue a lot about the data, but actually the data is information to inform our thinking, our judgments, and our choices. And if we can use the data as information and get less hung up on it being a point in time or a benchmark, we can then use it genuinely to drive forward changes in what we do for the better. So we can publish outcomes data, and we've seen the headline of naming and shaming, and actually focusing on the minimum standard. But actually, what is that for mortality? What's the acceptable mortality rate? It's really tricky. Once you get into measuring, particularly for a judgment, actually we start to lower the standards. When you get into measuring and thinking really about future outcomes, then actually you start to ease up the standard and think about how we can all be better. So there's a very subtle difference. So if we want to improve what we do, this work at the moment, although the report talks about quality data and mortality, is focusing on the mortality data. And I think somebody mentioned earlier about it not being survival data. It's kind of quite interesting because the Americans laugh at us sometimes about us being a health service, because actually they don't feel that we are a health service. They think that we're an ill service. And we use language sometimes that might reinforce that. So reframing some of this in a way which is actually about trying to improve survival, trying to help people have a better experience, can also be helpful. Thinking about the whole quality system. And there's a deliberate question mark in there, because I think that we don't know what really matters to all of the patients that come through our door, but we should be discussing with them what really matters, and we should be bothered about whether that is what happens. Getting back to work, being able to walk, running a marathon, they will vary by individual patients, but actually we're focusing at the moment on mortality. Makes it very bold, makes it a greater challenge. If we can have a range of quality measures in there that we start to think about in the local level, it helps us understand the broader perspective. So there is a need for consensus on the data that we're going to use. We need to agree the purpose. Is it for judgment, or is it to support change for the better? Agree what the data means. It needs to be seen as fair and credible, and we've already heard about the case mix comparison. But actually, the other thing about the data is how many patients or what percentage of the public would understand data on a case mix comparison. There's a real challenge here about how we work with our communications experts to make sure that we start to translate this so that it's useful for people and it means something, because this is about transparency and choice. So broadening the measures to include things that also matter to the patients on top of mortality, because as we know, nobody comes in expecting to die. And then actually aligning the transparency with the behaviours. Moving on to the culture, this is a really important thing, and it's an important part of it. If we get the culture wrong, people will retrench. So people come forward, and we've heard about huge numbers agreeing to be part of this initiative, and that is really fantastic. But we have to see it through by supporting the doctors that have chosen to do this. So there is this issue and balance about compliance versus commitment and what that really means. And I think that if we think through the kind of walking the plank with the walk the plank, no. Actually, would you take the plunge into best practice? Most doctors would say yes. So how are we framing it, and how are we getting people to think differently about how we want to set the culture for this work? So Just coming back to compliance and or commitment, there is a risk with compliance that you regress to the mean. What commitment can give you, as we've seen with the cardiothoracic surgeons, is a real drive towards improvement and within a relatively short time to have dramatic effects on mortality. That was driven by the commitment of the surgeons who really engaged in that programme of work. You could argue that compliance was there at the start, that there was a clear issue that needed to be addressed. The circumstances were right, there was alignment, the levers were in place. So you're never without an element of compliance in a system where public money is being spent. But the emphasis on commitment is the thing that will take this towards a greater and faster improvement. Focusing on strengths and not deficiencies. I think when we see our funnel charts, we look at the ones up at the top, don't we? But actually, if we do that, are we missing a huge opportunity to learn from those who are really excellent? So can we start to focus on the positive deviants and really understand what they do and learn and share that experience? So again, there is evidence that the higher you set the bar, the more likely it is that people will try to reach that bar. Doctors are highly competitive, actually. So they all want to be the best. So actually setting the best at a really high level is better than setting it at a minimum standard. So for the culture, there's an important thing about the messaging of this work. There's an important thing about the behaviours that are followed through, and leadership is needed. And that leadership needs to be consistent and it needs to be courageous, because we can't manage everything that extraneous that is going to happen. We can only manage what we can do for ourselves and our teams. Building commitment and focus on excellence. But the impossible dream, I'm going to use a story that you're all very familiar with now. So in 2010, Sky claimed that they were going to have a Brit winning the Tour de France within 5 years. No way. They were laughed at, actually. Brailsford was laughed at sitting in a cafe on the Champs-Élysées. But what he did was he set a really clear vision, which was highly ambitious. He got a shared common purpose. Everybody bought into it because as a team, they all wanted to win. The leadership was consistent and constant. They were very transparent about their goals. It was a very bold and brave thing to say, but he never wavered, even when they were losing, even when Bradley Wiggins dropped out of the Tour de France at the first try. They used innovation, they used lots of new ideas, they used technology, and it was those tiny little improvements that cumulatively got those seconds shaved off their final times, whether it was in a time trial or over the long days. And they didn't waver with all of the upsets, with all of the downs, with all of the critique from the press. But the other great thing was they then transferred all of that learning into a whole new team full of young British cyclists, and then did exceptionally well at the Olympics. So they've managed to spread and share, and it was done within 2 years. So is it possible in the NHS, and what would success look like for us? Because we don't get medals, we don't get glorious kind of podium placements, but actually we've done some really pretty fantastic work. And if we think about the enhanced recovery partnerships, within 2 years, this programme of work was spread in 85% of organisations across England, and it's now considered core business in the majority. The improvements for patients, the working with patients, patient-focused element of it has been key, but supported by data, very granular data, down to the level of consultant was absolutely critical. Saved lots of money, so quality can save money, and it was done at scale and pace within a short period of time. So I think we want you to consider the shared vision and purpose of this work when you go back to your locality. Think about the behaviours and values that we need to instil for this to be success and to become a programme of improving quality, and also the culture. Think about commitment versus compliance and the balance of that approach. And then not to forget that this is really about patients. It's about improving outcomes, improving quality. And we've got lots of system levers to maximise the effort of improvement. And I think also to think more broadly about the quality measures, so that it isn't just mortality that you're thinking about when you're considering improving the quality of care back in your areas. And I think I'm going to pass over to Julian now.
Ben mentioned earlier some of the way that local systems can help support this is there is much information already out there, and Ben referenced South Manchester, who brought together, in terms of pen portraits for all consultants, photograph, description, special interests, outcome data, and feedback from patients based on third-party assessments against a range of patient experience measures. This information exists, we can use this, and we can support transparency and improvements at a local level. How can we at a national level help in NHS IQ? Well, we want to act as a catalyst, we want to support collaboration, improve the knowledge and understanding of how to use data to support improving quality. And we'll be running workshops and events to bring clinicians together to focus on that. We will be working with a small number of specialist societies to improve understanding of the variation in data, support the spread of identified good practice, measure for improvement on an ongoing basis, and spread the learning, which is absolutely vital. And finally, what can you do to help? I think it's really important that some of the key messages from today are spread within your own local systems, and you're clear about the importance of this locally. Continue to grow the culture and values about the commitment to quality improvement, particularly in terms of the patient focus and supporting staff through this process. Spread and share the good work that's already underway. There is already some excellent examples of this in the NHS across the system, but arguably we haven't done this at a scale and a pace that we need to achieve. Build on this commitment to transparency that we are now clearly embarking on a journey in relation to this. There's the opportunity to link this to appraisal and to ensure that appraisal really means something in terms of continuous improvement, and the potential to link this to recognition and reward mechanisms within your own organisations to continually provide a spur and drive to improve. So that concludes the presentations.